Hello, my name is Jersey Lucier. Today I will be discussing and exploring the Bismarck healthcare model and how it is utilized in Germany. I will do this today by going in depth on the healthcare system within Germany and all the components and attributes that contribute to it. This entails the concerns and problems within the Bismarck system for Germany, how Germany's public health compares to other countries within the same model. These countries include France, Belgium, Japan, and the Netherlands, as well as cultural differences that healthcare workers need to be aware of and understand. Lastly, what healthcare workers can do to respect the cultural diversity within the country. To start off, I'm going to discuss an overview of the Bismarck system. The Bismarck model was born in Germany and named after Otto von Bismarck. Otto von Bismarck was the man who invented the welfare state as part of the unification of Germany in the 1800s. Through the Bismarck system, the insurance system is financed jointly on employers and employees through payroll taxes called sickness funds. In this multiplayer healthcare system, these taxes are deducted from paychecks. This model allows employees roughly 240 types of sickness funds that they are able to choose from. In order to create a better understanding, let's watch a video of an overview of this system.
The Mutual Insurance Model by Otto von Bismarck explained. In 1873, the German Chancellor Otto von Bismarck created the world's first welfare state. He introduced the Mutual Insurance Model, making it mandatory for all. The plan was to head off the upcoming socialists who were organizing themselves with all sorts of workers' health plans. Under the mutual insurance model, every working person contributes part of their income to a central fund. And if someone becomes sick, they're able to claim part of the costs back from this mutual insurance fund. Nowadays, these mutual insurance funds are still used in several countries, such as Austria, Belgium, the Czech Republic, Estonia, France, Germany, Liechtenstein, Luxembourg, the Netherlands, Switzerland, and Outer Europe, Israel, and Japan. The funds all work differently, but operate on the same basic principles, where you're free to choose your doctor. You pay for your treatment and then get reimbursed for part of the expenses by your mutual insurance fund. Reimbursement rates can vary between countries, as not every reimbursement system is the same. If you would like to receive full reimbursement for your medical expenses, you may want to take out an additional private health insurance to fill the gap.
Now let's discuss the utilization of the Bismarck model in Germany. In Germany, every single citizen and millions of guest workers are covered by healthcare plans. These healthcare plans are non-profit, meaning that they do not make money. Therefore, Germany, along with many other countries using the Bismarck model, house private hospitals and physicians. This healthcare plan covers everything ranging from prescriptions, doctor's visits, and mental health, and much more. In Germany healthcare, a difference from other countries is that they have a multitude of different insurers, ultimately granting the citizens of Germany a choice between competing insurance companies who cover their healthcare. As stated before, there are up to 240 sickness funds that they are able to choose from. In addition, no one is denied coverage in Germany through this healthcare system, even in the event that they do lose their job. Now I'm going to play a video that dives deeper into the Bismarck system in Germany in order to create a better understanding.
The last international healthcare system we covered, Singapore, got a great response from all of you. This week we head back to Europe. Specifically, we're going to Germany. Their universal healthcare system is based on the principles of Bismarck, which say that the state should provide only for those unable to provide for themselves. It's a private insurance system, and it's the topic of this week's Healthcare Triage. Health insurance is mandatory in Germany. Everyone has to get it. Before 2009, some of the richest people in Germany could choose not to buy insurance, but that's no longer the case. Insurance is sold only by nonprofit private companies. There are more than 130 of them, and they're also known as sickness funds. There's statutory health insurance, or SHI, or voluntary private health insurance, or PHI. PHI covers some of the benefits that SHI doesn't, but most are minor. It also gets you access to some better amenities and covers some co-pays for other services. 86% of Germans are covered by SHI and 11% by PHI. As with other universal systems, the insurance is pretty comprehensive. Coverage includes preventive services, hospitalizations, outpatient visits, prescription drugs, mental health, dental care, eye care, rehab, hospice care, physical therapy, even sick leave is covered. Long-term care is covered by a different insurance, but that's mandatory too. There are limits to this though, and some people buy supplemental private long-term care insurance. Any employed citizens and pensioners who make less than 52,200 euros a year and their dependents are covered by SHI. Anyone who makes more than that or who is self-employed can choose to get the SHI or buy PHI. About 3/4 of people choose the SHI path. There used to be no co-pays for SHI, but some were added in 2004. They were about 10 euros for a doctor's visit. But in 2013, most of those were removed again. There are still co-pays, 5 to 10 euros for prescriptions, but lots of drugs are still free, 10 euros a day for hospitalizations, and 5 to 10 euros for medical aids. Deductibles can vary by plan. There's no cost sharing at all for kids, and a cap on out-of-pocket payments at 2% of household income. That number is 1% if you have a chronic illness. Out-of-pocket spending accounts for just over 13% of all healthcare spending in Germany, making it slightly less than Canada, comparable to the US, but much more than France. About 72% of healthcare spending is public spending, and just over 57% comes from SHI. Employees or pensioners pay an 8.2% tax on their wages up to 47,250 euros. Wages above that are exempt from the tax. Employers contribute an additional 7.3% tax. The contributions are all put together and then spread out amongst the nonprofit SHI funds. If a fund runs low on money, it can charge the members a bit extra. In 2011, 13 of the 156 funds did so, to the tune of about 100 to 180 euros a year. PHIs are considered private health spending. There were 42 of them in 2011. Slightly more than half of them are for-profit. The other slightly less than half are non-profit. The premiums are risk-based on entry into the program, meaning that older and sicker people pay more. Employers make contributions to PHI as they do for SHI, but the employee contribution is higher. PHI is still tightly regulated by the government to protect consumers, though. Laws also encourage competition between the funds. Doctors belong to regional associations, which negotiate contracts with the various sickness funds. Outpatient docs work in private practice, for the most part, with 60% in solo practices, 25% in dual practices, and the rest in group practices. Mid-level practitioners, like physician assistants, are also employed in most offices. About half of physicians in SHI programs are family docs, and about half are specialists. Patients can choose any primary care physician, specialist, or hospital that they like. There's no real gatekeeping mandate, meaning that people can go to see specialists without first getting the permission of their primary care doctor. Although some funds do offer them, and offer incentives for using those gatekeeping functions. A relatively small number of people do, though. Most docs work in a fee-for-service way based on negotiated rates. There are preset maximum numbers of patients per practice, as well as reimbursement points per patient. This means that there are limits on the number of patients and number of treatments for which a doc can be paid each year. If a doctor goes over, they may not be paid. About half of all hospital beds are in non-profit public hospitals. An additional third are in private non-profit hands. The rest are for-profit, and that percentage has been growing. Most hospitals salary doctors who don't also work in the outpatient setting. The Federal Joint Committee decides what to cover and how to define quality. The Institute for Applied Quality Improvement and Research in Healthcare is responsible for quality assurance. Hospitals are mandated to report on 27 indicators so that they can be publicly compared. The country tries to control costs in a number of ways. There are a number of voluntary insurance schemes to do better disease management. Germany uses reference pricing with respect to drugs to try to get citizens to choose cheaper options. Basically, that means that the insurance will pay the amount of a cheapest drug in a class, and if patients want a more expensive one, they have to pay the difference themselves. A lot of research goes into deciding which drugs are most cost-effective. Finally, regional budgets are used to hold down spending. For instance, if a doctor goes over what's expected for prescriptions for their patients, they are held financially liable. In 2011, Germany spent $4,495 per capita on healthcare, or about 11.3% of GDP. That puts it on par with France. It's expensive, except for the US, which is insane at $8,508 per capita and 17.7% of GDP. But unlike some other countries, Germans have great access. More than 3/4 of Germans are able to get same-day or next-day appointments with their doctor, putting them at or near the top of the developed world. Quality is generally good. Life expectancy at birth is 81 years, making them 24th in the world. That's behind Singapore at 84, Canada at 82.5, and France at 82.3, but ahead of the UK at 81 and the US at 79.8. In infant mortality, it beats most, if not all, of those countries. Germany has an above-average number of physicians and nurses. They have a below-average number of CT and MRI scanners. Their preventable mortality rates are well below OECD average. A 2012 study found that Germany outperforms the United States and sometimes the UK in preventing death. It loses to France, though. Downsides? Because doctors are spread out so much, there can be gaps in knowledge about what patients have and what's been done. Surprisingly for Germans, it's somewhat inefficient. The fee-for-service model encourages more care, which some think goes too far. And some doctors hate the system, which can penalize them for doing too much. Germans worry that differences in physician salaries may lead to a primary care shortage in the future. Self-employed people also pay a lot for care, since they're responsible both for the employer and employee contribution. Finally, some claim that systems that employ tiers of coverage, specifically the SHI and the PHI, often lead to the wealthy doing much better than the not wealthy. But it's worth noting that the vast majority of people choose the SHI option. What keeps the public and the private option so close in terms of quality, costs, and benefits? Likely it's the German government, and there's a lot to be said for it.
Within the Bismarck system in Germany, there are a multitude of problems pertaining to it. For instance, an ongoing concern when it comes to this model is how to deal and care for citizens who are unable to work. It draws the question of how will their healthcare be paid for. In many cases, when someone does not have the ability to uphold a job for serious reasons, it creates the problem of how they will be covered. Another concern are the high mandatory employment taxes as a result to maintain affordable health care. A growing problem are the lack of healthcare services available to people living in rural areas of Germany. As you can see to the image to the right of my slide, the red dots are significantly more populated than the orange areas. The orange areas represent the rural areas. As you can observe, there are many more rural parts of Germany that lack this, that lack in healthcare. As the Bismarck model is used to cover every citizen in Germany, it poses the concern of how to deal with the aging population. Germany struggles when it comes to the uneven number of retired citizens to the working ones. Even though there are a multitude of different countries who use the Bismarck model, the health of their citizens does vary. The countries I am going to compare today are France, Japan, Belgium, and the Netherlands. To start off, Germany and France have very similar statistics, with the only main contrast being the number of physicians per 10,000, with Germany having 43 and France having 65.34. Overall, the health of both France and German citizens go hand in hand with the life expectancy, infant mortality rate, and obesity rate being very, very similar. When comparing Germany's and Japan's healthcare statistics, major contrasts are seen in each category, especially in the physicians per 10,000 and the obesity rate, with Japan having 24.8 medical doctors per 10,000 and Germany having 43 medical doctors per 10,000. It is important to take into consideration Japan's population, with Japan having a population of 125.8 million compared to Germany's population of 83.24 million. We can also look at the obesity rate, as Japan has a much more lower obesity rate than Germany. When looking into the obesity rate, we have to consider the health habits. These health habits consist of the amount of food consumed, physical movement, and how a country chooses to control its illnesses in the country. All these factors do contribute to the country's public health. Belgium and Germany are also very similar in their statistics, with the life expectancy of men and women being very similar, only ranging by 1 year. The only real contrast seen per this comparison is the physicians per 10,000, with Germany having 43 medical doctors per 10,000 and Belgium having 59.56 medical doctors per 10,000. Other than that, the two go hand in hand with very similar obesity rates, infant mortality rates, and life expectancy. Overall, Germany and the Netherlands have a very similar one as well. However, I was surprised to find out about the physicians per 10,000, given that the Netherlands only has a population of 17.44 million compared to Germany's of 83.24 million. However, the obesity rate, infant mortality rate, and life expectancy are very similar. However, the life expectancy for men does have a 2-year difference compared to the life expectancy of men in Germany. Now let's go ahead and talk about the cultural differences. Although German is the dominant ethnic group, Germany is diverse, as it is made up of many different ethnic groups, religions, and languages. This concludes that not every citizen will have the same outlook on healthcare as in the different types of care that they will receive and want to receive. With the ethnic makeup of Germany, including Turkish, Italian, Russian, Poland, Greek, they do offer completely different perspectives of healthcare, especially in terms of their cultural beliefs and values. Even though about 95.7% of Germans use the German as their official language, there are many other languages such as Danish, Slovenian, Romanian, and Serbian that are also prevalent languages used. So it's important to be aware of the diversity in order to provide the most understandable care. Religion is also a very important aspect to look in terms of cultural differences in the German healthcare system. Religion may alter how patients want to be treated and what care they want to receive. This also goes hand in hand with what they consent to in order to their belief system. Overall, it is very important to take into consideration every country's different diverse group. In every healthcare system, it is crucial to respect cultural differences. As healthcare professionals, As a healthcare professional, you are faced with many patients of different cultures, so it's important to familiarize yourself with different aspects of multiple cultures. Some of these may include personal space, language, religion, time orientation, and recognizing any prejudice. The amount of personal space between cultures varies, as some may get close or even show gratitude through a hug or a handshake, while in other countries this may be seen as disrespectful, as they value their personal space. Ultimately, when respecting cultural diversity, it's essential to always make the patient feel as comfortable as possible. In addition, respecting the cultural differences of a language by offering alternatives when faced with confusion. In order to communicate, it is essential that the patient understands, so offering a translator or being able to speak a multitude of languages may be necessary. In order to avoid any confusion or showing any disrespect, it is always important to show the patient that you care, that they understand. Religion is another aspect when respecting cultural diversity. As a healthcare provider, you must always be respectful of a person's choices, as it may be altered by their religion, and find another way that may agree with their religious beliefs when seeking care. Overall, recognizing any prejudices you may have instead of ignoring or accepting them is very important. Due to these biases, it may affect the care given and the overall outcome of the patient's health. In order to overcome them, it's important to increase contact with many people of different cultures and ethnicities, and motivate yourself to learn more and educate yourself on other cultural norms. Here are my sources for all of the research I did for this project. Thank you so much for listening.